Welcome to Mind Your Mental Health channel, a channel for mental health awareness, psychological health and well-being. This is our 31st episode, and in this episode we are going to talk about a mental illness called schizophrenia. It is one of the psychotic disorder. Psychosis or psychotic disorders are a group of disorders which manifest signs and symptoms of psychosis. In the last episode, I discussed about psychosis, its clinical features and causes and treatment and other aspects of psychosis. Schizophrenia is one such psychotic disorder. There are many psychotic disorders. Schizophrenia is one among them. Let's talk about schizophrenia. The word schizophrenia has its origin from Greek. Schizo or schism means split. Phrenia means mind. This is the term coined by a Swiss psychiatrist, Eugene Bleuler. He coined the term based on his concept that he felt that there is a split between different aspects of the mind. There's a split between thinking and emotion and behavior that he called as a dissociation. The split mind or schizophrenia should not be confused with split personality. Split personality is a different disorder by itself, which belongs to the neurotic disorders. Now it's a different disorder. What we are talking about, splitting of mind, different functions or different aspects of the mind. So he termed it as a schizophrenia. Since then, I think he termed it around 1908 or 1910. Since then, that word has been used to describe this disorder. In fact, before that, there was another name for this disorder that was called dementia precox. That was coined by another psychiatrist, Kraepelin. But currently, we are using the term schizophrenia. So, as it says, different functions of the mind, there is a dissociation. Let's see what is it. Now let me explain what are the signs and symptoms, then you will understand why we say there is a dissociation between different functions of the mind. When we come to the symptoms of schizophrenia, schizophrenia affects all aspects of the mind. You might recall, if you have seen the episode on mind, we have done a number of episodes on mind, different aspects of the mind. In those episodes, I said 4 important functions of the mind are perception, thought or thinking, emotions and behavior. Of course, we have few more functions like primary mental function, attention, concentration, but these 4, perception, thought, emotion and behavior, are core aspects of mind. In schizophrenia, all these 4 aspects of the mind are disturbed or affected. Let's take one by one. The perception. Perception is what we perceive through our sensory organs or sensory modalities. We see with our eyes, we hear with our ears, we smell with our nose. So these are the perception which takes in the information. This perception can be disturbed in schizophrenia. More commonly, hearing perception is disturbed, and that particular symptom is called hallucination. If it is hearing, it's called auditory hallucination. I'll explain to you about it. Hallucination, if you want to define it, describe it, we can say in a simple way, it is a perception without a stimuli. So when I see a light there, and I perceive it through my eyes. I see the light is on and it is emitting light and it is brightness. So that is a reality, that is a real. I'm seeing a light, I'm interpreting that as a light. Similarly, if I play music, I'm hearing a music coming from that player, and it is real. The music player plays the music, I'm hearing it. When it comes to hallucination, there may not be anything producing any noise or any music or any conversation. There is nobody around me. Still, I can say I hear voices. That is called hallucination. If it is voices, it is called auditory hallucination. If it is a vision, it is called visual hallucination. If it is some tactile perception, it is called tactile hallucination. So hallucination is a false perception. When there is no stimuli, you still hear something. So auditory hallucination was a common symptom of schizophrenia. They can have different types of hallucination. When I say hallucination, the patient typically will tell you, I'm hearing voices. I'm hearing voices talking about me. I'm hearing a person whom I know him about 10 years ago. Now I'm hearing his voices. If you ask him, is he there now? No, but I'm only hearing his voices. He is talking to me. So that is one kind of a hallucination. Other hallucination is where I say, there are two people in my house, when there is nobody in the house, there are two people in the house keep talking about me. They are discussing about me. They are planning to hurt me. They are planning to kill me. This is another kind of a hallucination. So it could be first person, it could be second person, or it could be third person, where two people discuss about the patient. In a direct command voice, like the voices can be directly talking to the patient. You are so and so, you are a bad person, you should be punished, why don't you hurt yourself, why don't you kill yourself? Or the voices might tell you, your friend is your enemy, he is plotting to kill you, he is actually a spy, he is spying on you, he has planted cameras all around your house. And the voices will talk directly to the patient, ask them, no, don't let him in, or try to hit him, try to do something to him. That is command hallucination. These are a different type of hallucination which a schizophrenia patient can experience. And one type of hallucination, they give running commentary. The voices in my head or in what I hear when nobody is around will give a running commentary about me. I'll give an example. For example, I hear a voice which tells you, Soundarajan, you are lifting your right hand and shaking your hands, and you are talking now. Oh, you're looking at the camera now. Oh, now you're looking at the lights. Oh, you're looking at the fan there. So that kind of, whatever I do, there is a commentary running up. That can be quite disturbing for the patient. It is called running commentary. No? And the voices can argue with the patient. Patient might talk back to the hallucination, the voices he hears. That's why sometimes schizophrenia patient, you can see they are talking. It's not they are talking to themselves, they might be talking to the voices they hear. They might have active dialogue with the voices. They might say, no, I'm a good person, I haven't done anything. The voices will say, no, you are a bad person, you need to be punished. That kind of a conversation will go on. So this is the kind of a hallucination, yes, schizophrenia patient can experience, and it could be quite distressing for the patient. Imagine a continuous voice telling me you are a bad person, you are a terrible person, or you have done so many things, you are a sinner. That voice can be very disturbing for me. So that is one of the symptoms, very important symptom of schizophrenia. Then next to the perception, we have an aspect of a mind called thought or thinking. Thinking is a very common, we always think. No, there is no life without thinking. We continuously think, sometimes we overthink. We'll talk about overthinking some other episode. So the thought process can be disturbed. So when we think, there is a coherence between different ideas. Now thinking is a flow of ideas initiated by a problem ends in a solution. That is a simple definition of a thinking. So when I think, suppose I'm feeling hungry, I want to eat something, I think about food. Whether I should have it at home or go to the restaurant, which restaurant I go to a Chinese restaurant or Italian restaurant, whatever restaurant I go to, and what I'm going to have. Whether it's a lunch or a breakfast, that is the coherence of the relevance of the ideas. One idea follows and there is a connection between one idea and other idea. This connection might be discontinued or disrupted in schizophrenia patient. So they might have loosening of association. That means one idea and other idea is not connected. They may start about thinking about food, then jump to something else. That will be completely not connected to the subject they started thinking about. And it can lead to irrelevant talk. They may start, you might ask a question, what did you have for your breakfast? They may start off initially, but they'll drift away. Their talk can be completely irrelevant. That reflects loosening of association in their mind. And the ideas which runs through in their thinking process are not connected. They're loosened. They are distorted. So that is one of the symptoms of schizophrenia. Other symptom is the schizophrenia patient might think their thoughts are not their own thoughts. Somebody is inserting the thought. What I'm thinking now is not my own thinking, doctor. Somebody is putting in my mind. That kind of expression they have. And they also feel that the thoughts are being telecast or broadcast. They might come to the psychiatrist and say, other day I was looking at the TV, I can see whatever I think in my mind, which is internal, I can hear it on the TV. The newsreader was talking about it, and he was just talking about whatever I was thinking. That is thought broadcast. And it might expand to say that my thought is known all over the world. So it is not more, it's no more private thought. It's broadcast over the telecast, and everywhere people can hear my thoughts. And they can also tell you, my thoughts are being withdrawn. There is no thought in me, doctor. I'm blank. My thoughts are withdrawn completely. That is another kind of a thinking process defect in schizophrenia. And they also tell you that whatever I think within me, I hear it as an echo. No, it sounds as if it's coming out and I hear it through my ears. That is called thought echo. And other than that, they can also have delusions. I've discussed about this, all these symptoms, when I made a episode on signs and symptoms of mental illness. I discussed in detail about that. If you are more interested in this, you can always go back and watch those episodes. These are the first 10 or 12 episodes. I talked about basics in mind and mental health. Delusions are unshakable false belief, not in keeping with their educational or cultural background or social background. So I'll give an example. Suppose I have a thought which tells me, and which I believe that my neighbor is trying to harm me. In fact, they are trying to kill me, and they are the agents of MI6 or MI5 or some international spy ring, and they are following me all the time. And they are trying to kill me in different ways. When I go to the shopping center, when I go to the high street, they follow me, doctor. I know they follow me. How do you know? I know the two people are talking, and I'm sure they are talking about me. So I'm quite scared, doctor. Anytime they might kill me. And they might also go on and say, when I'm at home, even the doors are locked, they try to get into my room. They go through all my documents. They go through all whatever here in the house. They are trying to find out something against me. This is called delusion. And the person will firmly believe in that. For them it is real. You might say, when you come across a patient like this, you might say, no, that is false. There is nothing like that. The neighbor is not like that. No, they are nice people. No, they care about you. But the person will say, no, you don't know. I know. Because their conviction is 100%. It's unshakable belief, and it is a false belief. And it is not keeping with their cultural, educational, or social background. Suppose I have that thought, being a doctor, being a psychiatrist, if I have that delusion, it is not keeping with my educational, professional, or cultural background. So that's the definition of delusion. So the patient suffering from schizophrenia can have different types of delusion. There are different types of delusion. I'm not going to go into the detail because I will try an episode on that. So one of the common delusion is paranoid delusion or persecutory delusion. That's where they think people are against them, trying to harm them. And another delusion is called referential delusion. What it means is the patient will believe that two people are talking among themselves, they are talking about me. There will be real two persons talking on high street, and as a patient walking by, and patient will look at it, immediately the patient will think, okay, they are talking about me. They might be talking something else about the politics or the movie they saw. But for patient, they are talking about me, they are planning to kill me. That's a kind of delusion. That is a referential delusion. They can also say that TV news is referring me. They are talking about me in that news, and they were telling that there's a person called Dr. Soundarajan, and we need to go and watch him carefully because we need to do something about it. That kind of a thought they have, and they believe. That can lead to a lot of distress and a lot of other complications. And there are two more symptoms I'm going to talk to you. These symptoms are mostly seen at a very early stage of the disorder. If the person comes to me after 1 year of onset of the disorder, onset of schizophrenia, I may not see this symptom. It's in the early stage. I would say first 1 or 2 weeks of the onset of the illness, you will see this. There are two symptoms. One is called delusional percept or delusional perception. Another one is called delusional mood. So delusional percept is a perception leading to delusion. Delusional mood is an uncanny feeling that something is going wrong, something is happening, suspicious thoughts or some kind of uneasiness, leading to kind of a paranoid thought or suspicion. These two occurs in a very early stage. I'll give an example for delusional percept. I go to a restaurant, I order for a cup of coffee. The bearer brings a cup of coffee and leaves in front of me. It's a nice cup, china, and there's a teaspoon there. And I look at the teaspoon. On the teaspoon, it's a steel, very nice looking spoon. On the handle of the spoon, I see a crown etched, beautifully etched, nice crown. It's a decorative piece. The moment I see that crown, if I develop delusional percept, that perception, that looking at the crown in my teacup or coffee cup triggers a thought that I belong to royalty. I am related to royalty. I am related to the king. I shouldn't be here. Actually, I should be in the palace. Why am I here? That is delusional perception, where a perception leads on to sudden onset of delusion. It is out of the blue, sudden onset. It could be preceded by delusional mood. As I entering the restaurant, I might have that delusional mood. I might think something wrong here. I feel very uncomfortable. Unease feeling is there, and I feel there's something wrong going on. And why these people are looking at me? There's something wrong. Then I look at the cup. Then I look at the spoon. Then the crown. Then that triggers a delusion. That is delusional perception. We don't see that at the later stage of the illness. We see the early stage of the illness. There is a couple of more symptoms which is very pathognomonic of schizophrenia, or made affect, made behavior, or made action. What it means is, whatever I do, I'm moving my hand, looking at the camera, and looking at the lights, or wherever I'm looking, I'm doing it myself. It is my action, my behavior. In a schizophrenia patient, if they develop this particular symptom, they feel what they are doing is not them. Somebody is making them do, like a puppet. They feel that I'm raising my hand, I don't want to do it, somebody is making it. Somebody making me do that. Similarly, I don't want to be happy, but I'm still smiling. That is because somebody is making me smile. So that is the made effect or made action, where patients feel they are doing things not themselves, somebody is making them do. They are feeling something which is not their own feeling, somebody is making them feel that way. These are also very pathognomonic symptoms of schizophrenia. There is one more symptom where they say thought block. Now suddenly the thoughts becomes completely blank. They go completely blank. So that can also be a symptom of schizophrenia. But one symptom does not lead to a diagnosis. Because as I was talking about thought block, I'm just thinking all of us would have got some kind of a block sensation when you're anxious or something else. That is not schizophrenia. I'm talking about a different symptom where completely everything is completely gone. The thoughts are not there. So that is thought block. Okay. So these are all some of the symptoms relating to the thinking. And then comes to the emotion. The emotions can be very inappropriate and incongruent in a schizophrenia patient. Inappropriate, they might go to a wedding and start crying. That is inappropriate. They go to a funeral and start smiling or giggling. because of the internal thought. That's what drives them. So that is inappropriate. Incongruent, they may say I'm very happy, but at the same time they'll be crying. So that is incongruent. So mood can be quite bizarre, inappropriate, incongruent, or they can have a blunted mood. They may not have any expression in the face. That happens when the disease advances. When you have a schizophrenia for years and years, what we call chronic state, or it's also called as undifferentiated schizophrenia. So prolonged illness has those effects. Those effects are called negative symptoms, where they don't react, they don't talk, they withdraw, their speech becomes very sparse, very slow, very few words, they don't respond immediately, there is no alertness, there is no kind of a movements which normally accompanies when we talk. All those things comes down and they go blank, and then they don't react to anything. These are all negative symptoms of schizophrenia. That happens in the later stage of the illness. Now, then the third aspect of the mind is behavior. So when your perception is abnormal, when your thinking is abnormal, your emotion is abnormal, we can expect the behavior to be abnormal, because their behavior will be mediated by the thoughts what they have. Abnormal thought, the thoughts are that they are deluded, that people are against them. So the behavior will be very in tune with the suspicion. They lock the door. Now, I have seen a patient who had about 16 locks on their door, fearing that somebody might come when they sleep. And I've seen a patient where in a bright sunny day, you would have closed all the doors, all the windows, drawn all the curtains, thinking that somebody is monitoring from outside. I can't open the window, doctor. Come in. No, don't keep the door open. I know there is a man standing there watching you entering, and he is the man who is trying to kill me. So the behavior will be in tune with their thought process. Sometimes behavior can be bizarre also. And another behavior we noted, especially in chronic condition, is self-neglect. They don't bother about their looks, appearances. They don't look after their personal hygiene. They may not take bath for days, weeks, or even months. So they can neglect that. Self-neglect can creep in. And they will not progress in life. They will come down in their social ladder. They can't hold a job. That kind of effects happen in a chronic schizophrenia. A trained mental health professional, a psychiatrist, psychologist, or psychiatric nurse will be able to make out the reliability and the validity of the symptom. What if I go and tell someone I'm hearing voices? The person who's assessing, who's going to spend 1 hour in that assessment, will know you are having a hallucination or not. That comes by training and observation, looking at every aspect of the patient and corroborating all the information patient give. Because anybody can come and say, I'm hearing voices. Doctor, diagnose me schizophrenia. Now that's a difficult task, because I can't prove or disprove. I'll have to rely on the patient. But our experience, our training, our knowledge in the basics gives us the skill, the talent to find out, okay, this patient suffers from schizophrenia. So that is the signs and symptoms. We elicit extensive history and look at all the symptoms and then formulate it. Then we make a diagnosis of schizophrenia. Next is, there are different types of schizophrenia. Now, there is a change in that typology now. We don't use many of these types now. We have moved away recently only, in the recently published classificatory system by WHO, we are moving away from types of schizophrenia, what we used to have in the past. In the past, that is advantage of being in psychiatry for 45 years. Now, you know what happened in the past. So, in early days, I'm talking about 70s and 80s, we had different types of schizophrenia. We had a simple schizophrenia, we had a schizophrenia called heavyphrenia, and we had a paranoid schizophrenia, we had a catatonic schizophrenia, and we also have an undifferentiated schizophrenia. These were some of the types of schizophrenia we had. Simple schizophrenia we stopped diagnosing that condition long time ago, because it's quite a broad category, broad type, and there is a risk of not a person with schizophrenia being included in that. So there is also some geopolitical and other issues relating to simple schizophrenia. So that diagnosis dropped from the official practice. Schizophrenia we used to make, I remember making that diagnosis in 70s and 80s. Schizophrenia starts much early in the age, around adolescent, early adolescent, and it runs a very chronic course, and it is very deteriorating schizophrenia. And the predominant symptoms is giggling and hearing voices from the fan and very bizarre delusion and bizarre hallucination. That prognosis is not very good for this type of schizophrenia. Most common type is paranoid schizophrenia, where predominantly patient will have auditory hallucination and persecutory delusions, where they think people are trying to harm them. Some of the example I gave is paranoid schizophrenia. Catatonic schizophrenia is mostly manifested in the behavior. They go completely motionless, like they go withdrawn completely. They may not move from one place. They might stand in one place for hours and hours together. Now, some of the patients I've seen, they stand in the garden or somewhere and look at the sun. Keep looking at the sun, not blinking, just looking at this. They don't have any movement. Their movements all come down. It's called catatonic withdrawal. In the extreme case, they may not eat, they may not drink. It could be a risk to life. And catatonic withdrawal one end, but catatonic excitement is the other end, where they become extremely excited, and also sometimes they become extremely violent. And you need to be very careful dealing with these patients. Another type of schizophrenia is undifferentiated schizophrenia. What it means is we are not able to differentiate the type of this particular person's schizophrenia. And it might have a mixture of symptoms, and we are not able to put into one particular type. So that is undifferentiated. Usually we see that in a very chronic condition. Suppose patient comes to me after 5 or 10 years of illness, believe me, people do come after so many years, because they may not know they are suffering from mental illness, and they may not know they have illness. So those kind of patients, we see this undifferentiated schizophrenia. Prevalence. So next let's talk about prevalence. How prevalent is the disorder in the community, and what are some of the features of that? So lifetime risk of developing a schizophrenia, some of the research findings are that it's about 1% in the general population. And schizophrenia illness is found in men and women equally. There are some mental illness which are more common in women, and some other mental illness are more common in men. But in schizophrenia, the incidence of schizophrenia in men and women are almost equal. Age of onset is, in men it's much earlier compared to women. In men, the age of onset is about late adolescent to early adult, about 15 to 25 years. In women, the age ranges from 25 to 35 years of old. And in women, it ranges from 25 to 35 years. That is onset. That's the time they develop the illness. That's early onset or early manifestation of the illness, and that is the time. And we have also seen patients in much earlier age. We have also diagnosed schizophrenia in much younger, in the children age group. That's defined in different format, and the management, everything is completely different. And some of the research pointed out that schizophrenia is more common among urban population compared to rural population. And it is also more common among lower socioeconomic groups compared to the higher socio. These are all some of the research findings. There are also research findings which may not support this. And another finding is more diagnosis made in immigrant population. When they move from one country, their parent country, to some other country, live there, they have more chances of developing schizophrenia. The reasons are many. The reasons are speculative, but there are many. The reason could be the stress, or the deprivation of the cultural change, and the sudden change in culture, their habits. All those things can contribute to stress, that can contribute to schizophrenia. So these are all some of the kind of features of schizophrenia. One more factor is, a few researchers also pointed out that patients born in winter months have more chances of developing schizophrenia. So don't be alarmed. Now, if a child is born in a winter period, don't think that they're going to become schizophrenia. Now, in psychiatry, I'll talk about it when we come to the causes of schizophrenia. So it's all kind of a research findings which says it could be a possibility. So winter month, there are more chances. There are also research pointing to it could be a slow virus. None of this has been conclusively proved. These are all different hypotheses, comes from data available from research. Okay, that brings on to what causes schizophrenia. Why do people develop schizophrenia? It's a $1 million question in mental health. In mental health, we don't have single cause. Unless it's like post-traumatic stress disorder where one trauma produces a problem. Many of the psychiatric disorder, the causes are due to multifactorial reasons. Now we broadly call them as biopsychosocial. Bio means biological bodily changes, psycho means psychological, social means social reasons. So let's take one by one. Biological reason. We know very conclusive evidence that in schizophrenia patients, there is a definite imbalances in neurotransmitters. Neurotransmitters are neurochemicals. I have done an episode on that. Please go back and browse that. So neurochemicals imbalances can lead to schizophrenia. There are a number of neurotransmitters: dopamine, glutamate, acetylcholine, and norepinephrine. There are a number of neurotransmitters which acts in the brain. They are the fundamental mechanism which makes us think, whatever we do, it's because of the neurotransmitters. And mostly they are in brain, they are also in other parts of the body. So some of the neurotransmitters imbalances can lead to schizophrenia. Most important one is dopamine. That was the neurotransmitter studied much earlier. We have a lot of data on that, research findings on that. Then glutamate is also another. Glutamate is also another neurotransmitter implicated. And that is bodily. And when we come to biology or biological genes, it is also known by different studies, genetic studies and family studies and twin studies. These are the different studies we do to ascertain whether the disorder is due to gene transmission. So the findings suggest that schizophrenia can be transmitted through genes. When I say that, again, don't be alarmed. If father has a schizophrenia, does not mean son or daughter should have a schizophrenia. That kind of a transmission is different. That is autosomal dominant, and it comes directly. What we are talking about, the gene produces a propensity in that person to develop schizophrenia. Suppose I have that gene. Somewhere down my hereditary or my ancestors, I have that particular gene. That means I have the chances of developing schizophrenia. So propensity to develop schizophrenia. That will happen only when other factors are combined together. It could be bodily changes, neurotransmitter changes, or it could be psychological factors or social factors. If all three join together, then the gene will express itself into a schizophrenia disorder. Otherwise, patient may not have schizophrenia for their whole life. So genetics does play a role, but it is a different kind of a role. And research has also found there is a difference in the brain development of a person suffered from schizophrenia and a person who has not suffered from schizophrenia. This again, the research finding, there are definitive developmental changes are there. Whether we call it as a developmental disorder, we haven't reached that stage yet. So these are all some of the bodily causes of schizophrenia. Psychological, there are many theories have been promoted in psychological theories. The contradictory communication is given to the child as the child was growing. That can in the future lead to this kind of breakdowns. Again, those were not subsequently followed up, researched and concluded as 100%. These are all some of the findings which comes through. And social causes, again, more than the precipitating, it can have effect on the social structure or standing. A schizophrenia patient might lose a social stature. A top executive in a company developed schizophrenia when he was 30 years old. Till the time he was a top executive performing so well, bringing in so much money to the organization, then he develops schizophrenia, then everything comes down. His concentration goes, and he's not able to concentrate because of the delusion. He's not able to listen to people in a meeting because of the hearing voices. His performance comes down. He might lose lose his job. He must lose his livelihood. From excellent residential house, he might move to kind of smaller houses, and you can even become homeless. So that is called what social ladder. They'll come down in the social ladder. So that can happen in schizophrenia. And stress. Now, stress can trigger schizophrenia. One more important factor is alcohol and drugs, especially cannabis, can trigger schizophrenia. Many people ask me when I talk to them, when I see a patient with cannabis dependent, they ask me, they don't believe in me. They might say, no. I've seen people using cannabis for years and years. What, doctor? I don't think that it causes schizophrenia. No, not every smoke, every puff of cannabis can induce schizophrenia. We are not talking about that. We are talking about use of cannabis abnormally for a long period of time in a patient who has propensity to develop schizophrenia. Suppose my grandfather or somebody had schizophrenia, and that gene is transmitted to me. I have the gene in me, and I have not had schizophrenia because there is no reason for it to express. There is no psychological reason or biological reason or social reason. But one fine morning at the age of 30, 35, I go start experimenting with drugs and then get hooked on to cannabis. That can trigger or express the schizophrenia. That is one possibility. And cannabis, long use of cannabis itself can cause psychosis, what we call the cannabis-induced psychosis. So these are our triggers for developing schizophrenia. So we looked at the symptoms, we looked at the types, we looked at causes. What causes schizophrenia? Next question is, how do we treat them? Is there a treatment available? Yes, there is a treatment available. There are a number of methods of treatment available. Broadly in psychiatry, we classify them to medication and psychological treatment. So before going on to the medication psychological treatment, we need to understand how we are going to approach the patient. Suppose patient comes to me in an outpatient department, there is no risk to this patient, and I make a diagnosis, and I say, I elicit some information which is disturbing. I think there is a risk there in this patient, and I need to manage the risk, so I need to start the treatment immediately. That is one scenario. And I feel risk is very high. If he goes home, something is going to happen, then I would say you should get admitted to the hospital because you could be a risk to yourself or others. So best outcome will be admit you in the hospital, observe you, and give you all the treatment and care you need. I negotiate a treatment, patient agrees, comes into the hospital. This is the second scenario. First, outpatient treatment. Next, inpatient treatment for a willingly coming in patient. The third one is, the patient refuses admission. He says, I don't have any mental illness. The patient might say, my neighbors are trying to harm me. They are plotting to kill me. You don't believe in me, you are believing in them. Probably you are conniving with them. So I don't believe in you. I even doubt whether you are a doctor. I don't need admission, doctor. This is called one of the symptoms of schizophrenia, lack of insight. They lose insight into their illness. They think they are not having any mental illness. They are all right. They are normal. Everybody else around them who say that what you are thinking is wrong are abnormal. So that can lead to a situation. Patient thinks that he's been persecuted and he wants to hurt that person or do something to them. He says, when I go home, I'm going to challenge them, I'm going to punch them. There is a risk, both to the person who is accusing and the patient himself. So this risk needs to be contained, and I'm asking them to get admitted to the hospital. That's one effective way of managing the risk. But they're refusing. In this kind of situation, if the risks are very high, if I'm really concerned about that, then I might to bring in certain other provisions to override their refusal to admission to a hospital and admit them compulsorily. This can only be done by a proper legal procedure. These procedures are well laid down in Mental Health Act. In United Kingdom, we have a well-established mental health act. And we practice that, we follow that provisions, all the subdivision sections and clauses. You can use the act and then admit them against their will. So this is the situation. Like one is outpatient, next one is voluntary admission, third one is involuntary or compulsory admission. Okay, that is the that's how we approach. Now let's come to the treatment by itself. As I said, there are medications, there are psychological therapies. There are a number of medications. All these medications are collectively called as antipsychotic medication. Usually in my episodes, in my program, I don't mention medication names because it could be misleading for a patient. That's the only reason. I would love to explain about individual medication, all those things, but it could be misleading for the patient. If a patient is listening to my program, if I say medication A is excellent, B is not that good, or I say we prefer this for this patient, he might already be receiving some medication which may not go all correctly with what I am talking about, because each medication is prescribed to individual patient depending on their circumstances. I won't be able to say this will be good for you. I might only say generally, but patient make it very personally and they might go and challenge the doctor. So that's why I don't mention medication particular name, I only mention the groups. Okay, so we have antipsychotic, excellent medication, antipsychotic medications are available. We can treat the patient with that. Medication can give symptom relief and they'll be able to bring up some of the capability they have lost because the symptoms are gone, so they can feel much better and there'll be improvement in overall. And in medication wise, we acutely patient comes to us with florid symptoms, then we the first criteria, first task for a psychiatrist is to control the symptom or remove the symptom. So we give medication for that. Then symptoms, depending on what happens, symptom completely removed. Now patient becomes completely asymptomatic. There is no symptom at all. Delusion is gone, hallucination is gone. Then the patient might ask me, shall I stop the medication? It's all gone. We'll not stop the medication because there is something called maintenance treatment. They'll have to continue the medication for a longer time. The psychiatrist will be able to decide when to change the medication or when to reduce the dose or when to stop the medication. Till that time, patient need to continue the medication because schizophrenia is a severe and enduring mental illness. It runs a long course. For example, if I have a diabetes, it's not going to be cured by 1 week medication or 1 month medication. I need to take it for a longer period. I might be able to control my diet over a period of time. I might reach a stage where, okay, I can reduce the medication or something, but I'll have to take the medication for a very long time. Similarly, schizophrenia is also a disorder, which is a chronic disorder, enduring disorder, severe disorder, which has a propensity or chances of relapses more. They come back, the symptoms will come back. So maintenance medication is very, very important. Usually we maintain the 1 or 2 medication. We don't give multiple medication. Initially we might give medication to control their psychotic symptoms. We might have one more medication. We might have some medication for sleep. And if they are depressed, we might have medication for depression, all those things. But when we come to the maintenance, we might give 1 or 2 medication, or there are some medications available, what we call as a depot injection. You take injection once in 2 weeks or once a month or once in 3 months. And there are medications which is coming up, you can take it once in 6 months or once in a year. That kind of medication is also available. Depends on the patient. Everybody can't go for those kind of medication. We need to assess the patient and match the medication with the patient. Okay, so maintenance medication is also very, very important. That brings on to another question of compliance. Now, patient need to be compliant with the medication. They'll have to take the medication regularly as prescribed in the dose prescribed. Otherwise, there will be recurrence or symptoms will come back. It's natural. If you are giving me medication for weeks, months and years, I might get to a stage where I don't want to take medication. I'm all right. Why doctor is making me take medication? So I might stop it. So compliance is very important. That's why we need to counsel the patient when we start the medication. You need to take it longer time. This is the one which makes you all right. Usually I draw a parallel or example from diabetes. If I am a diabetic, I take medication, blood sugar comes down. And a couple of weeks later, blood sugar is normal, I can stop. I will stop then blood sugar will go up. Similarly, in the psychotic or schizophrenia patient, as far as you are taking medication, symptoms are controlled or gone. If you stop the medication, they might come back. The chances of coming back is high. So that's why we need compliance. They need to comply with medication, whatever the medical or the mental health team advises them. Then that brings on to psychological treatment. Most of the mental illnesses, we do propose or we do think about psychological treatment. Sometimes psychological treatment may not be available due to resources and other reasons, but psychological treatment forms very important aspect of whole management of the disorder. In schizophrenia, first is psychoeducation. Now, where we explain about the disorder, tell them this is what is happening to you, this is what you require. Now, if you stop the medication, this is what's going to happen. These are the complications, these are the risks. So, psychoeducation is one. Then there is a therapy called cognitive behavior therapy. It's a very excellent research, evidence-based treatment, which is also offered to schizophrenia patient. CBT, so cognitive behavior therapy in short form called as CBT. CBT is given for patients with depression, anxiety, phobia, obsessive compulsive disorder, or post-traumatic stress disorder, and even a patient recovering from physical illness, cardiac rehabilitation patient can also have CBT. So that's kind of a breadth of that therapy, the effectiveness of that therapy. And in a psychosis patient, in a schizophrenia patient, there is a CBT tuned for psychosis, tuned for schizophrenia patient. That CBT can be offered. And some patients who have gone into chronicity, very, very burnt out, negative state of schizophrenia, they might require rehabilitation because they would have lost all the skills of social skills of living. They may not cook, they may not know, they're reluctant to do anything, they may not look after themselves. As I say, they might neglect self-negligence, they may not brush their teeth, they may not look after themselves. Now they might be very smelly. So these kind of patient needs rehabilitation, where in a center they are admitted, keep them for a longer period, 6 months or even a year, rehabilitate them and give them the training, give them the skills of everyday living, budgeting skills, and nowadays we need to have little bit of IT skills also. All those things can be imparted to that person, and so that they can live well in a community. So rehabilitation for a period of time, then when they are well equipped, they go back to the community. This is also part of the treatment. And there is also another method we use is self-help group. Patients who have completely recovered or they are in the recovering stage and they are doing well in the community, they can form a group. They can form a self-help group with the help of a professional or without the guidance or monitoring of a professional. They can form a group and they can support each other, learn from each other, because every schizophrenia patient goes through their own experience, which is uniquely different from other patients. They may not replicate the same experience in other patients. Generally, certain things will be commoner, but personal experience will be different. People can learn from that. Now that's what we call learning from experience, or they are called experts from experience. So these are all some of the outline of management of schizophrenia. That brings on to the another question of, there are a couple of things. One is risk, other one is prognosis. Risk is schizophrenia patient can have a risk behavior stemming from their delusion. If I am paranoid about somebody, I think that is a person who is going to harm me, I might harm them or harm him. That is a risk to others. Or I might feel overwhelmed about the whole situation. I think that person is harming me, they is trying to kill me, and nobody is believing me. My wife is not believing me, my children are not believing me, why should I live? They might commit suicide or attempt suicide. So risk to self is there, risk to others is there, and self-neglect is another risk. They may not eat, they may not take the medication. If I have a hypertension, diabetes, they may not take those medications. That can lead to risk. So these are the risks accompanying the diagnosis of schizophrenia. Risk varies. Now, some people may not have any risk, some people have all the risk, and our treatment plan depends on the risk. That is about the risk. Another thing is, after the psychotic episode, now I am fully deluded, I have lots of delusion, I hear voices, everything gone. I am in the hospital 15 days, I have taken the medication as prescribed by my psychiatrist, every symptom is gone. This is called post-psychotic period, where the psychosis is gone. In this period, they might regain the insight and they might realize what they have done. I shouted at my neighbor thinking that he is trying to kill me. All those things will have an impact on them. That is a period high risk for attempting suicide or completing suicide. We need to be careful about that also. Post-psychotic, we call it as a post-psychotic depression, and that can lead to suicidal thoughts. So this is the risk. The prognosis, we can broadly group them into 3 groups. About 20% of the patient can become completely all right. They might have one episode and they're treated well, 2 months, 3 months, 6 months, they're maintaining well, 1 year, there is no recurrence, there is no re-emerging of symptoms, then we might say they are completely cured of schizophrenia. It happens in 10 to 20% of the patient. First onset psychosis, early detection. That's why we need to detect or identify schizophrenia early onset. I said, remember one symptom, delusional person, which comes in the very early, say, first 2 weeks of the illness. If you are able to identify at that time and treat them effectively, adequately, with all the modalities of treatment, they can become 100% all right. So early detection and effective early intervention is very, very important, paramount in managing schizophrenia. So 20%, one group is 20%. Other group, about 30-35% or even 40%, will have fluctuating course, ups and downs. Now they get treated, they take the medication, they're all right, relieved of all the symptom or at least 90% symptom, they maintain a good progress, and then they might stop the medication or something happens, some stress factor or something happens, they'll have a relapse or they'll get back the symptom again. It goes up and down. They get the symptom comes down, remain well, then again they get the symptom. It goes on. Each symptom, each relapse, each coming back of symptom worsens the prognosis of the patient, worsens the future possibility of complete recovery. That's why we need to maintain the stability, the improvement with the treatment at a stable level with effective and adequate treatment. So that is the second group, ups and downs. The third group is they go down. That could be about another 20-25%. They have a downhill course. This is what we used to call as a process schizophrenia. I'm not going to kind of confuse with all those technicalities. We call it as it's a core schizophrenia where they deteriorate. In spite of all the treatment, any kind of a treatment they give, they don't respond well. There is no symptom removal 100%. Symptom might come down 20%, 30%, 60% to 70% symptom will remain. They might talk to themselves. They might hear voices, they may not be risk. They might lead a life, sort of life, with the symptoms. Remember Beautiful Mind movie? Remember what happens at the end? The professor? Did the symptoms, hallucination gone away? No. He learned to live with that. If you haven't seen, go and see the movie. Beautiful movie. Beautiful Mind. Yeah. Okay, let's come back to the subject. So the third group is chronic, where there are very, very negative symptoms. They may lose all their emotions. They may not look after themselves. They need support. They need round-the-clock support sometime. Initial days when we need to bring them back. So they need a very intense support. So 24-hour support worker. All those things needed. That is one group of schizophrenia. So to sum up, we discussed about schizophrenia as a disorder. It is a psychotic disorder. Psychosis is an enduring and severe mental illness. Schizophrenia is one such mental illness. I explained about the word schizophrenia. I talked about symptoms and signs of schizophrenia. And I talked about prevalence rate, 1%, and equal in men and women. And in men, onset is early, 15 to 20, 25 years. In women, it is later, 25 to 35 years. And then I talked about types of schizophrenia. I said we don't use the typology now. Then I talked about the causes of schizophrenia. I cautioned you because we don't have a conclusive kind of research say this is the cause. We have multifactorial reason. Researches are still going on. One day we will find out the core cause of schizophrenia. Probably AI, artificial intelligence will help us. Then I talked about treatment. I talked about generally how we approach the treatment, the medication, then psychological and rehabilitation, all those things. And I also mentioned about risk and how they improve, what is the prognosis of these patients. Thank you very much for listening to this long episode, because it had to be, because I want to give you a lot of information. These are all very important information. Why I am giving this information? There are two reasons. One is general public. They don't have schizophrenia illness, or none of their relatives have schizophrenia illness. For them, it is a knowledge. It is information. If they come across early symptom of schizophrenia, they will be able to talk to someone. Now, if they see a friend and who has some of the symptoms I said, then they can probably discuss, or they can have some kind of a support to him. Or there's another group of persons who is watching this program. They could be a relative of a patient diagnosed schizophrenia. It will be of immense help to them to understand what is this process and why people are behaving that way. Because people, without realizing what is going on in the mind or what is happening to them, they might misconstrue them. They might think he is doing it wantedly. They might even react to them negatively. So they need to understand the patient. This episode will help them. Third one is patients themselves. They might have heard this when they were into a mental health team. They would have explained all those things. Still, it's a recap. Now it comes from a different person. So that will be helpful for a patient also. That's the reason why we do this kind of a quite detailed program, and which runs for, many of my program runs from 20 to 30, 35 minutes. Okay, so we'll conclude this episode, and then the next episode we'll be talking about another psychotic disorder called delusional disorder. Thank you for being with us. Continue to support us. If you like the program, do say that you like it, and you can comment it, and you can also share it with your friends and relatives if you think it will help them. Thank you.